Good morning, good afternoon, and good evening. It's my pleasure to welcome everyone to the plenary session on newborn survival at the CUGH conference. I'm joined today by my colleague, Dr. Maria Oden. My name is Rebecca Richards-Kortum, and we are both on the faculty in bioengineering here at Rice University, where we co-direct our Institute for Global Health. Today, we're here to talk about the important challenge of saving newborn lives. Neonatal conditions are now the leading cause of death in low-income countries, and the vast majority of neonatal deaths are preventable. Today, we will have a great opportunity to learn more about global efforts to improve newborn survival and eliminate preventable newborn death across the world. We have just such an amazing lineup of panelists who will share their work in India, in Africa, the United States, and all around the world. We will first hear from each of our panelists, and then we will have a question and answer session at the end. If you have questions for our panelists, please put your questions into the Q&A window and indicate which panelist you would like to have answer your question.
First on our panel, I have the pleasure of introducing Dr. Gagan Gupta, who is the maternal and newborn health specialist at UNICEF's New York headquarters. Dr. Gupta is a neonatologist and led the UNICEF Newborn and Child Health Team of India for 7 years. We are very excited to have Dr. Gupta with us today, and he will share lessons learned scaling neonatal care in hospitals across India.
Good morning, good afternoon, and good evening, colleagues. A very warm greetings to all of you from UNICEF headquarters in New York. I'm Gagan, and over the next 10 minutes, I would be sharing with you the story of newborn care units of India. It's a story which not many believed a decade back could be written in a low middle income group country like India, to virtually breaking the glass ceiling in 2018 with 1 million newborn admissions in a single year itself. The story is also a story of moving from a UNICEF-supported pilot in just a few districts to a national scale-up using domestic resources. It's an example of how a strong government leadership, backed up with right partner support, can bring the change at scale and in a short duration of span. Often the story of India is spoken as a story of large numbers. It's a story of 25 million babies born each year, 500,000 of which die in the first 28 days. The narrative that India contributes to largest number of newborn deaths will not change soon, given the difference in the neonatal deaths in India versus the other top 4 countries. But what is changing is the share of India's contribution to global burden. In the early 2000s, India was contributing to 31% of the neonatal deaths, and this has now reduced to 21% in 2019. In early 2000, the focus was mainly on the community-based care, the home-based care and the IMNCI, and that was right at that moment of time, given the fact that half of the women were delivering at home. But the narrative is now shifting from home to hospitals. In 2005, when our newborns were born in these huts, with every second woman delivering at home, to 2015, when our newborns are now in the hospitals, with 8 out of 10 deliveries happening in a health facility. This also meant that there was an increasing load of newborn coming to the hospitals and the increased load of referrals coming through the community-based programs. And the big challenge we had was, how do you maximize the gains of facility births for newborn survival? And the big opportunity was the launch of National Health Mission in the year 2005. This got the resources, both the financial and the human resources, and brought in the provision of decentralized planning and innovations. And this was a wonderful opportunity for investing in the facility-based newborn care, which can reduce neonatal mortality significantly. So what the focus of the program was to converge at the opportunities around birth for the triple returns on investment. bringing women for safe delivery through a 24/7 transport network, ensuring essential newborn care for all babies, and for those who are born small and sick to have the special care through the special newborn care units, and integrating the WASH in the health facilities. The whole spectrum of the facility-based newborn care included the newborn care corner at all delivery points, the stabilization units at the sub-district level, at the district level, a level 2 newborn care unit, and kangaroo mother-father care in the vicinity of newborn care units for the stable preterm babies. Now, there were 5 key areas where we worked together which are the prerequisite for a successful rollout. The first and foremost is ensuring the budget lines in the national, state, and district plans. The second was the investment on infrastructure upgradation. The third was putting in place a system for equipment procurement and maintenance. The fourth was getting the human resources right. And last was putting a monitoring system in place. And what is important is you need to work simultaneously on all these 5 aspects and not sequentially. Now, just to go more in detail on the HR policy changes that were done by the government to address the staff crunch. This involved pay hike at all levels for doctors as well as nurses, walk-in interviews to ease the people getting into the system, difficult area allowances, and flexible pay. There was something called U quote V pay policy, where people to go in the difficult area can quote a pay package which government was willing to give. Enforcement of 2-year service bond for the fresh postgraduates, and also task shifting where training of the medical graduates was done for the newborn care. Now, if you look at the results, starting from a pilot in a few states with 18 units built between 2007 to 2009, in 2018, we had 840 newborn care units with 1 million admissions in a single year. And the domestic resources of more than $400 million were invested by Government of India for the scale up and maintenance of these units. Now, the big question was, how do you track the outcomes? What's happening to the babies in the newborn care unit? And what happens to them when they go back home? To address this, we started a SNCU online monitoring system. This was piloted in 2 units, and the focus was to get real-time information on more than 250 parameters to help the program managers, the SNCU staff, and the policymakers to take corrective action. Starting from 2 units, this has been scaled up now to 875 SNCUs with 5.8 million admissions and 570,000 deaths captured in this. This is now one of the biggest and the largest real-time online data for small and sick newborns globally. And if you can see, there are 2 major components. One is uniform data recording. So all newborn care units are now recording data on a set of uniform parameters. And then this data is entered online, and there's a dedicated data operator in each unit who makes sure that everything is entered online on the same day. Now, just 2 pieces of evidence which have come from this data and have influenced the policy. The first was looking at the care in the labor room. And this is the data of the deaths in the SNCU who are about 2.5 kg babies. And of the 117,000 babies who have died in last 6 years in the SNCUs, in the about 2.5 kg, the birth asphyxia was accounting for 61% of these deaths. Overall, across all weight categories, birth asphyxia was around 30 to 35%. But in about 2.5 kg babies, birth asphyxia remains a major cause. And this led to looking at the labor room, and a huge program called CUGH was launched to improve the quality of care in the labor room. Now, if you see, a 2.5 kg baby should have no business to come to the newborn care unit. And if the baby comes, there's no business for the baby to die. But that meant that we need to work more on the skill attendance at birth, the emergency obstetric care, and the neonatal resuscitation. The second important piece of evidence which came from this data monitoring was the follow-up system. If you look at this data from 3.5 million babies who were discharged from 2013 to 2019, nearly 1 out of 4 babies was below 2 kg on discharge. Now, when a baby is still below 2,000 grams on discharge, you also need to continue hypothermia prevention, feeding support, hygiene, and optimal development. And that means there's a need for continued care at home and in community. And this extends the continuum of care back to community, the place where they come from and the place where they go back to. And the government of India started a system where the counseling and screening on discharge was done, and the follow-up at the hospital, as well as follow-up in the community by the community health worker was initiated. So as I conclude, what helped in the scale-up of the newborn care units in India? First and foremost, the intervention addressed the need on the ground. The intervention was very much required because of the increase in the institution delivery and more newborns coming to the health facility. The second thing was seeing is believing. We created pilots with government and the exposure visits. This led to the belief that this can be done. The strong government leadership by Government of India, ensuring dedicated funding lines under the national budgets, and continued support by the partners during scale up. So as I conclude, let me quote something what our ex-president APJ Abdul Kalam said. Dream is not something that you see in sleep, but dream is something that does not let you sleep. And our government had this dream, UNICEF had a dream, and a lot of academic institutions, National Neonatology Forum, and everyone came together to fulfill this dream in the country. Thank you so much.
Thank you, Dr. Gupta. As a reminder, if you have any questions that you would like for us to pose to Dr. Gupta at the end, can you please enter them into the Q&A, and we will be tracking them and ask the questions at the end. Next, I have the pleasure to introduce Dr. Chinyere Ezeaka, who is a professor of pediatrics at the College of Medicine, University of Lagos, Nigeria, and the head of the Neonatology-Perinatology unit at the Lagos University Teaching Hospital. Dr. Ezeaka will share her work as part of the NEST program. NEST is an alliance of international organizations working with local governments to end preventable newborn deaths in hospitals by delivering a package of technologies and services that save newborn lives and empower the medical workforce of the future.
Good day, everyone. For this session on newborn survival, achieving SDG 3.2 in less than 10 years, I'll be making a presentation on overview of NEST 360 UNITAL quality improvement implementation in Nigeria. Globally, we have about 2.6 million newborn deaths worldwide, and Nigeria carries a disproportionate burden in Sub-Saharan Africa, where we have about 250,000 newborns dying every year from largely preventable and treatable causes. This is huge for us in country and a cause for grave concern. Out of these 2.6 million, we have 1.1 million of these newborn deaths in Africa. What are the major causes? We're looking at prematurity, we're looking at infections, and we're looking at babies who did not breathe at birth. And this mirrors the same scenario we have in Nigeria. It has been projected that it will take about 100 years for a baby delivered in Sub-Saharan Africa to have the same chance of survival for a newborn delivered in the high-income countries. This is huge. And every expedited effort should be consolidated to reduce these deaths in less than 10 years. That is why we're here. That is why the team is all working towards reducing these deaths, both in Nigeria and many other Sub-Saharan African countries. So NEST 360 came into Nigeria in 2019 to cover major gaps. So we're looking at key areas like technology, where they're bringing innovation. We're looking at human resources, where there's capacity building and training. We're looking at implementation gap, where there's data and research, and we're bringing market shaping and distribution gap to be closed, in addition to other programs already ongoing in Nigeria and many other Sub-Saharan African countries. So actually, these 4 key gaps are really very crucial in reducing neonatal morbidity and mortality in all these phase 1 countries. So the story of NEST in Nigeria started in June 2019, when we had the first major stakeholders meeting, where NEST leadership came to Nigeria and met with policymakers, government, clinicians, engineers, professional association leaderships, who include neonatologists, pediatricians, private practitioners, biomedical engineers, and entrepreneurs. And we had representatives from all the 6 geopolitical zones of Nigeria. Also, we also had the key development partners who are working in the area of newborn space in Nigeria: WHO, UNICEF, USAID, Save the Children International, Pathfinder International, Integrated Health Program, Nigeria. All these actually make up the National Newborn Technical Subcommittee of the Federal Ministry of Health. Well familiar in most facilities where we have these equipment graveyards. And NEST is working on reducing some of these equipment graveyards, whereby they're coming up with effective, affordable, low-cost, sustainable equipment, not just to give them to not just to develop, but also to repair and maintain a distribution line for this equipment. And this is actually what is happening currently in Nigeria, in addition to the other NEST implementation countries. So we have a newborn now to speak about this technology. What do these technologies mean for an ill child? A newborn who is ill, a small preterm baby, needs a bundle of technology to survive. And we're looking at respiratory support. This baby needs to breathe. We're looking at feeding, hydration, nutrition. We're looking at temperature stability, which is key. We're looking at monitoring and treating jaundice, then having other point of care diagnostic, measuring glucose, having equipment to diagnose, treat infections in these babies. And all in all, for the baby to achieve this, there must have been planned to have a separate neonatal ward for the baby. And this is key because it is a gap in many facilities in Sub-Saharan African countries. So this is looking at the spread of the bundle of equipment of the NEST implementation. And this equipment are already in country in Nigeria. And not only is NEST speaking about bundle of technologies that these newborns need, NEST is looking at complete system change. It's looking at integrating the quality improvements for national policy change to reduce the morbidity and mortality in neonates. We're looking at implementation guide, financing guide, pre-service education, in-service education, and then supervision and mentorship is integrated in the entire program. So NEST started off with in Nigeria, started off with one key achievement we have recorded till date, whereby working with the Federal Ministry of Health as the lead, we've been able to develop and finalize the first national guideline on comprehensive newborn care and a training manual in the country. Initially, most of Nigeria's newborn trainings were centered around essential newborn care. We're looking at neonatal resuscitation, we're looking at breastfeeding, we're looking at immediate care of the newborn. But actually, in country, we recognized that there was a gap for care of the sick and small newborn in the being taken care of in the facilities. And again, many of these trainings will actually refer these babies to the secondary and tertiary facilities. And when these babies get to the tertiary and secondary and tertiary facilities, there are not enough equipment. We're looking at oxygen, we're looking at phototherapy, we're looking at bubble CPAP to make these babies to breathe. We're looking at monitoring equipment like glucometers, we're looking at oxygen concentrators, we're looking at pulse oximeters. So these are key, and this is what NEST has brought on board. So working with the national body, working with the Federal Ministry of Health and the national stakeholders working in the newborn space, we've been able to conclude on that guideline, despite the COVID, having series of virtual and physical meetings when it was possible in 2020. And this document was presented to the Federal Ministry of Health in November 2020. So we can say that since within NEST is looking at being country-led and country-owned. Now in the area of this equipment, the equipment was, we had a national launch of the equipment in November 2020, where the equipment had been brought to the 2 learning hubs. And it's not just equipment. This looking at strengthening biomedical engineers and inventors to have a streamlined education process whereby they can innovate those equipment and produce them in country. And already these design studios are being set up at the University of Lagos and at University of Ibadan, which are the 2 learning hubs. Now, also looking at innovation, NEST is also testing out a crucial point of care bilirubin machine that is going to detect the level of the bilirubin from these babies, which has been a key gap of detecting the level of bilirubin to diagnose jaundice. And without that diagnosis, one could not have undertaken effective treatment. So this is very important. So still on the gaps that NEST is filling in Nigeria now, we've produced the document, we've launched the equipment in country. One other key area is human resource capacity building and trainings. That the first ever comprehensive newborn care trainings have been rolled out in the country from December 2020. And this is very important that this first training has actually, I must say, has been catalytic in that it has now led the Ministry of Health to plan more step-down trainings across the country, and including the biomedical engineers and the clinicians. The key area, these are trainees being trained on capacity building for NEST. One key area for NEST is on data. Data is needed for national quality, drive quality, and have sustainable action. So at the national level, NEST has worked to strengthen the data system in the country and integrate sick and small newborn variables across board. So, and then in the area of market shaping, NEST has also engaged a national distributor so that will sustain that this equipment are not only being maintained, but equitably distributed and regularly available across board in the country. So the key messages are NEST is one of the countries in Sub-Saharan Africa. Nigeria is one of the countries in Sub-Saharan Africa where NEST is being implemented, carries a high burden of neonatal deaths, and is strategic to the achievement of SDG 3.2 in Sub-Saharan Africa. And for us to accelerate progress, there is great need for strategic partnership and collaborations for quality comprehensive newborn care to reach every sick and small newborn in their remotest area in Nigeria. And using the NEST 360 ideology of having cost-effective equipment, human resource, data, sustainable distribution channels in the crucial bid to achieve SDG 3.2 in less than 10 years, so that we can save lives and every baby survives and thrives to attain their life-giving potentials. Thank you very much for listening. Thank you.
Thank you so much, Dr. Ezeaka. We have heard about a really amazing program in India and a huge effort in Nigeria, and now we move around the world back right to where I'm sitting, to Houston, Texas. It's a real pleasure for me to introduce our next panelist, Dr. Charleta Guillory, who's an associate professor of neonatology at Baylor College of Medicine, and she's the director of the Texas Collaborative for Healthy Mothers and Babies Neonatal-Perinatal Public Health Program. Today, Dr. Guillory will share her important work to understand and reverse the persistent inequities in newborn health outcomes in the United States. Welcome, Dr. Guillory.
Good afternoon. My name is Charleta Guillory, and I'm an associate professor of pediatrics at Baylor College of Medicine and a practicing neonatologist and director of the Neonatal-Perinatal Public Health Program at Texas Children's Hospital, which has one of the largest neonatal intensive care units in the country. Today, I will be speaking on behalf of the 4 million infants that are born every year in the US and evidence of their infant mortality. I have no financial relationships. The infant mortality rate is defined as the number of deaths that occur before the infant's first birthday per 1,000 live births. The infant mortality rate is a leading health indicator that provides insight into the health of infants, mothers, and the larger community and overall health of a society. According to the CDC, the 2017 US infant mortality rate is 5.8 deaths per 1,000 live births, which is less than the Healthy People 2020 target of 6 infant deaths per 1,000 live births. Geographically, infant mortality rates in 2017 were highest among states in the South and some states in the Midwest. The infant mortality rates range from 3.7 in Massachusetts to 8.6 in Mississippi. Translated, it means greater than 23,000 babies died in 2017. Texas infant mortality rate was 5.9 and higher than the national rate for the first time in 10 years. This is concerning, and following the trends will be important. When we look at infant mortality by race, ethnicity, the US infant mortality rate for non-Hispanic Blacks is 11 deaths per 1,000 live births. Just as in the US, the overall decrease in infant mortality observed in Texas over the past decade was not equally distributed across all racial ethnic groups. Black infants are dying 2.3 times the rate of non-Hispanic whites and Hispanic infants. Well, what are the leading causes of infant mortality? Both in Texas and the US, the leading causes of infant death in 2017 are congenital malformations first, second, premature birth and low birth weight infants, third, leading cause of death for infants are maternal pregnancy complications, followed by sudden infant death syndrome. The leading cause of infant death also differs by race, ethnicity. During the same time period, the major cause of Black infant death was preterm birth. Black babies in 2017 were more than 3 times as likely to die of a premature birth-related issue as babies born to white mothers. A mother's socioeconomic status and access to quality health care and nutritious food can have a substantial effect on her baby's health, and public health experts say disparities in infant death rates often reflect broader inequalities. In a population health study done by Dr. David Lakey and team at the University of Texas Health System and presented at the Texas Collaborative for Healthy Mothers and Babies, they looked at Texas infant mortality rates by zip codes. These zip code level data shows that despite our state's relatively low infant mortality rate, substantial variation exists across zip codes. Some zip codes in our state did not experience a single infant death in the 4-year study window between 2011 and 2014, whereas others experienced more than 1% of their infants dying before the first birthday. These data documented the wide geographic variation in the state and in the cities and demonstrated substantial variation within racial ethnic groups. Zip codes with both low and high rates of infant mortality could be found for all groups, Hispanics, white, and Black infants. In Houston, for example, the mortality rates for Black infants varied 8-fold, from 3.3 deaths per 1,000 live births in zip code 77077 and 28 deaths per 1,000 live births in zip code 77026. Thus, race, ethnicity cannot be the sole explanation of a community's high or low rates. Unfortunately, the data doesn't explain why the variation exists. There's substantial evidence that social, environmental, and economic factors at the community level partially explains this variation. Socioeconomic status of the community, income inequality, and air pollution are three community level factors that have been found to be related to infant mortality. Obviously, expanding this existing research to understand how these factors are playing out across communities in Texas and the US will be an important next step. You have already heard about the high infant mortality rate in the US and in Texas. The question is, how does maternal mortality affect infant mortality? This is an important relationship because the maternal-infant bond is severed. In addition, some of the same solutions to decrease maternal mortality will decrease infant mortality. We know that pregnancy-related complications, for example, diabetes, are closely tied to infant deaths. And there's data that shows maternal mortality increases the risk of delivering a premature infant. And we know that prematurity is the second leading cause of US infant mortality rates and the first leading cause of infant mortality in African American women. Unfortunately, when a mother dies, her infant is at a disadvantage, as opposed to other infants who have not experienced a loss. The family remaining will need to provide support while still grieving. Well, who pays for the first year of care during the first life of these babies? We all know that health insurance coverage is an important determinant of access to health care. Newborns under 12 months born are to Medicaid eligible mothers are automatically eligible for Medicaid and remain eligible through the month of their first birthday. Children who do not qualify for Medicaid because of income may be eligible for CHIP and may qualify for special needs programs at or below 198% of the federal poverty level, which is approximately $3,429 per month for a family of 3 in a household. Medicaid for pregnant women have the same requirement as described before. I think it's important to note, as we talk about infant mortality, it is so important that access to health care is a major portion of caring for these babies in the first year of life. In 2017, the number of uninsured children increased for the first time in decades. It went from 276,000 more US children became uninsured, including 83,000 in Texas. And in 2018, the number of children enrolled in Medicaid and CHIP fell by over 840,000 nationwide, including 145,000 in Texas. But for newborns, 58% of all Texas births, we said there are 4 million births in the US, Texas has 400,000 births in the US, in Texas, which means we really have 10% of all births. And in that 10%, approximately 54% are paid for by Medicaid. If, however, they have a code of prematurity, then greater than 67% of the babies in our neonatal intensive care unit are paid statewide by Medicaid costs. If you have a premature baby during that first year of life, the cost can be as high as $100,000 compared to that of a term infant of about $572,000. Well, there are many different solutions, but I'll just highlight the Texas solutions to decrease infant mortality and improve infant outcomes are many. Specifically in Texas, we've established the Texas Collaborative for Healthy Mothers and Babies. We've established the Perinatal Advisory Council to look at designations of care for our neonatal intensive care units, since many of the babies die in that time period. We have a maternal mortality task force identifying the causes of maternal death. And Texas has a collaborative relationship with the American Academy of Pediatrics, Texas Pediatric Society, Committee on Fetus and Newborn, and we're working on projects to improve the overall care of newborns, whether it's hearing screening, the Texas Pulse Oximetry Project, or improving screening for critical congenital heart disease. Overall, we have individual responsibilities for this disparate healthcare. And we as individuals have to stop blaming victims and really denying that implicit bias and structural racism does not play a part in the numbers that I have just given you. We need to begin to look at our patients in the eyes and empower them with evidence from best practices. And most of all, we need to listen without judgment and with empathy as we provide care to these 400,000 deliveries in Texas and 4 million deliveries in the US. Thank you as we challenge ourselves to improve the health of a nation, standing with mothers and babies.
Thank you so much, Dr. Guillory. As a reminder, I see some questions starting to go into the Q&A box. Please keep those coming, and we look forward to having a vibrant question and answer session with our panelists in a moment. Finally, I have the pleasure to introduce Dr. Rajiv Bahl from the World Health Organization. Dr. Bahl is the coordinator of the Maternal, Newborn, Child, and Adolescent Health Research and Development Team at the WHO. His team develops research, guidelines, tools, and training materials for maternal, newborn, and child health. Today, Dr. Bahl will be talking about global progress to date toward achieving SDG 3.2.
Thank you so much, Rebecca. I actually will talk a little bit on the evidence, new evidence from WHO coordinated research to accelerate newborn survival with a focus on sick and small newborn. And I will, in the short 10 minutes that I will use for this presentation, focus on 3 stories which address the most common causes of death in newborns in the world, particularly in the low and middle income countries in South Asia and Sub-Saharan Africa. So the 3 things I will talk about are sepsis treatment and expanding its coverage in low and middle income countries, antenatal steroids and how to ensure safe and effective use in low and middle income countries. And the third will be maximizing the impact of kangaroo mother care on newborn survival. And the 2, antenatal steroids and kangaroo mother care, are the 2 most important interventions probably for preterm birth in these settings. So the first story is around the treatment of infections. Again, it is not enough time to go into details, but only a quarter of all newborns with sepsis receive the recommended hospital-based treatment in low and middle income countries. And you can see on the right side, there are 4 papers published in the Lancet and Lancet Global Health in 2015, where WHO coordinated research showed that where hospital treatment is not possible, outpatient treatment with oral amoxicillin and intramuscular gentamicin once a day was safe and effective for most of the children with possible serious bacterial infection. Of course, this does not include the very sick, critically ill kids. So the WHO guidelines were released in 2016, and the thing I wanted to just share with you is lessons from implementation research in 6 countries that have happened since 2017 to 2020. And these are all published in a series of papers in PLOS ONE last year and this year. And the highlights are that we could achieve very high coverage. When we added this strategy to hospital-based treatment, we could achieve very high coverage of population-level treatment of newborn infections and sepsis to the tune of more than 60% in most settings. with very low treatment failure rates relatively. I mean, compared to the hospitals, it's not too different, and low mortality below 2% in program settings. High coverage required that outpatient treatment was available at multiple levels of the system, and some other factors that were associated with success was postnatal home visits and local technical support provided to the program. The second story is on antenatal corticosteroids. Again, a very short story of a very long series of things that needed to be done. The Cochrane review, on antenatal corticosteroids includes more than 20 studies, largely from high-income countries, and shows a large neonatal mortality reduction. But a study in low and middle-income countries, coordinated by NIH MCH network in 2015, published in 2015, showed the opposite. It showed a 12% increase in neonatal mortality when the antenatal steroids were scaled up in these settings, and showed no effect in small babies, but in large babies born with larger weight and larger gestation, there was an increase in mortality. Now, there were three possible explanations of this. One being that the selection of the women who were given steroids in that study were not appropriate. And we took that from, the hint from that was that only 16% of women who received steroids delivered preterm, the remaining delivered at term. The second possibility was that there was inadequate care for preterm birth, such as infection treatment, and therefore, if there were any side effects, children were dying because of that. And the third was that maybe in low and middle income country conditions, the steroids are not really needed and not effective. To solve this problem, at WHO, we coordinated a multi-country study in 5 countries of Asia and Sub-Saharan Africa, which was published late in 2020 in the New England Journal of Medicine. You can see the paper on the right, and which showed 16% fewer neonatal deaths in the antenatal steroids group, and 30% lower need for resuscitation, and respiratory support was also reduced, with no increase in maternal or newborn infection. And just to mention here that 90% of these babies delivered preterm. So what was the difference between the two studies, and what were the lessons for the programs? Firstly, that reliable ultrasound-based dating is probably going to be required in these settings, even if this ultrasound-based dating is in the 3rd trimester. Obstetric care providers needed to be competent to identify imminent preterm birth, because otherwise a lot of mothers get the steroids and don't have birth, thereby having no benefit and possibly having harm. And finally, a minimum package of care for preterm babies must be available, which included infection treatment, feeding support, KMC, CPAP, and monitoring, thus linking to what Gagan and Chinyere have presented, that we need a concrete level of support for other interventions to work. The last story that I'm going to share with you is about KMC. Now, of course, KMC is known for past 2 decades and has been recommended by WHO for 2 decades and shows that it reduces mortality. We have evidence to show that it reduces mortality in stable low birth weight babies by 40%. But the WHO coordinated KMC research program was put in place in 2016 to address 3 key gaps. Why then is the global coverage still low? It was less than 5% at that time. So learn how to achieve high coverage. Secondly, evidence was there only for KMC initiated in hospitals. Does KMC initiated in the community or at home also save lives? This question was unanswered. And finally, most preterm deaths actually occur before the baby is stable. So does KMC initiated immediately after birth save even more lives than what is currently recommended, and the use, as Gagan was talking about, in KMC units, etc.? So the first question was addressed in about 8 million population in Ethiopia and India in several districts in these two large countries. And the implementation research question was, what are the barriers and how can those barriers be overcome to achieve high coverage in different contexts? The research was iterative cycles of implementation, qualitative and quantitative data collection, and optimization of an implementation model. All I want to say here is, and this was led by the state or the regional Ministry of Health in India, the National Health Mission, in Ethiopia, the regional health bureaus. All I want to say is very high coverage relatively from that less than 5% or almost non-existent levels to initiation of 68 to 88%. And even if we counted more than 8 hours of skin-to-skin contact per day, 53 to 82% KMC coverage at a population level was achieved. The major reasons, which again, I will not go into details, are on this slide, and I will highlight only 2 of them. The most important probably issue that I want to highlight is that the respect and care for mothers, to allow them to be with their babies and to provide them with a bed, food, toilet, bathing facilities, was probably the most important factor, whether KMC can be scaled up or not. Just having something by the side somewhere will not work. So the second most important thing was the conviction of the staff that KMC is the standard of care and not just an add-on after everything else has been done. Government ownership and system changes is key. The second story, and I'll finish in a couple of minutes, is around the community-initiated KMC. This was again not an implementation research study, but a large randomized controlled trial involving 8,000 low birth weight babies in India, and was published in late 2019 in the Lancet, and showed a 30% higher newborn survival with KMC initiated in the community versus no KMC initiated in the community. And as I said, in these settings, less than 5% of babies had KMC before they were discharged from the hospital. And these babies were stable and above 1,500 grams because we did not want to go into the very high-risk babies at home. The important point to make also is that the benefit did not end at neonatal period, but continued to 6 months of age. And you can see the survival curves diverging even at that point in time. The last thing I'm going to talk about is the Immediate Kmc Trial, and that the design of which is again an individually randomized controlled trial in several countries, as was listed on the slide, with 4,000 babies. These are now the very small babies who are admitted to these newborn care units, and they are weighing between 1,000 and 1,800 grams. The intervention is KMC initiated as soon as possible after birth by a mother or surrogate, where control was KMC initiated after the baby is stable. So it is the current recommendation of KMC is the control. Primary outcome is mortality. Just to show you a glimpse of what it needed, what was necessary to achieve this zero separation between the mother and baby and to implement IKMC, you can see in the pictures what we created in all these settings is a mother newborn intensive care unit or mother newborn special care unit, not just a SNCU, but a place where mother was an integral part of the system. She was in there along with all the other equipment, all the other needs which are there in the NICU. The important thing here to note is that the presence of the mother in the NICU is a key intervention without which you can't change what is happening. You can't actually get immediate KMC. And provision of all care, including respiratory support, is provided along with KMC, whether it is oxygen or it is CPAP. These babies were not really the ones who were put on ventilatory support, as these hospitals, actually most of them or almost all of them, did not have any ventilation support beyond CPAP. Control arm is the usual care, babies in these units with warmers, with all the equipment, and some of them in cots if they are getting better and are fully stable. I am not at liberty of sharing the results of this IKMC project because the paper is currently under consideration for publication by the New England Journal of Medicine. But watch this space. We have completed and submitted. These are really interesting results. But overall, all I wanted to say is that translation of all these findings into practice in low and middle income countries has the potential to save over 1 million lives per year. And added to what has already been said by Gagan and Chinyere, and reducing inequities, as Charleta was talking about, we can achieve this feat. Thank you very much.
Thank you so much, and a big thank you to all of our speakers in today's session. In the time that remains, we are going to turn to the questions that have been submitted from the audience. And I believe that the first question is directed toward Dr. Gupta. And the question is, could you please say more about the training to improve breastfeeding outcomes in your program in India?
Thank you so much. So the breastfeeding for small and sick newborn care itself is a whole separate issue, because if you see, overall there are gaps between institutional delivery and early initiation of breastfeeding. The institutional delivery in India is around 80% plus, but early initiation of breastfeeding is around 45%. So every second baby who's delivering in a health facility is actually not getting early initiation of breastfeeding. Now, these challenges get further compounded when a baby is in small and sick newborn care unit. The reason is often the baby is separated from the mother. Often the baby, because of medical conditions, is put on parental fluids. So besides early initiation, the second important challenge is to sustain breastfeeding. And that becomes a very critical issue, to sustain breastfeeding from a mother who has been separated from a baby. The baby is not feeding, and the anxiety which mother faces when the baby is in the newborn care unit. So one of the important things which was done right from the design phase was breastfeeding was integrated in the design of the newborn care units. And every unit had a newborn care area where the breastfeeding can be done. In addition, the mothers were kept in the vicinity of the baby. So the design included a mother's ward in the close vicinity of the newborn care unit, so that mother can come inside and be with the baby to help that kind of breastfeeding. And staff was also sensitized in terms of the importance of ensuring the maintenance of breastfeeding. In addition, later on, as the model evolved, there was incorporation of the family-centered care, where mother was more and more closely engaged. And Dr. Aarti Maria and their group did this very good work on the family-centered care. So it evolved right from the design stage to further strengthen through the family-centered care and the part of the training as well. But challenges of newborn care unit get further compounded because of the challenge of sustaining breastfeeding during this environment when the mother and baby are separated. Over.
Thank you so much. This next question is for Dr. Guillory. The attendee writes, as a public health professional who just gave birth to a premature baby in Texas during a global pandemic, I was incredibly surprised at the variation in quality of care from provider to provider, particularly the paucity of patient-centered care and education and prep of parents in basic life-saving skills versus a very strong emphasis on breastfeeding. Dr. Guillory, you're asked if you can share more about how initiatives in the United States are strengthening patient-centered approaches and prep for addressing issues when skilled birth attendants and providers leave.
Well, I think that's a very important question. The first thing I would like to say is that there was a paper that was just recently published, and it was by Dr. Rachel Hardiman and team in Florida, and she's in Minnesota. And one of the things they actually looked at was the fact that Black providers caring for Black babies within the neonatal intensive care unit had improved outcomes. So I think this is really challenging that they would begin to think out of the box. For many years, people have felt that once you get in the neonatal intensive care unit, you do not see implicit bias, that all babies are treated equally. But, you know, for me, it's a matter of why would you leave those prejudices at the door when you go into a neonatal intensive care unit? And it's not until we begin to face our implicit biases, face the knowledge that we have, that we know our outcomes are different, even in the neonatal intensive care unit, that we really are going to be able to address these things. The second thing I'd like to mention in regards to this question is that California collaborative, their perinatal collaborative, actually under Dr. Joachim Prophet, has looked at different intensive care units and found that depending on where you deliver, the care, of course, is suboptimal. So, and when you look at these different hospitals, you may have more Blacks delivering in the suboptimal hospitals. So that's the second thing I'd like to comment about. And the third thing she said in terms of breastfeeding, one program we have here is the Honey Child program. And actually, after years of working in NEO, I really wanted to go further. So I obtained a master's in public health right here at the University of Texas School of Public Health, and actually tried to see what things could we do in Houston with African-American women to decrease the prematurity rate. And at the same time, when we helped develop the Honey Child program, we wanted to make sure that all of our mothers breastfed. And the one thing we did, the one thing that we changed is that we said, we expect you to breastfeed. It was like, and it's not that we didn't give you an option, but we assumed it was the best thing for the baby. We assumed that it's almost like you had to opt out of breastfeeding. And what we found in that group, we had a prematurity rate in Texas of 18.9 premature births per 1,000 deliveries. And in the Honey Child program, we were able to get it down to 11 in the very high risk group. But specifically, we had 100% mothers breastfeeding in our neonatal intensive care units, in the regular nurseries. And it was just simply by educating the mothers, making sure they knew it was the best thing for them, changing the culture of how we do in terms of breastfeeding. And I think that's a small scale, of course, but I think that could be done. And we actually worked at that here at Texas Children's as a part of the collaborative to increase human milk in the NICU. And as part of that project, we specifically made sure that there was an emphasis to make sure our Black mothers were breastfeeding. And the final thing we did with that is we know that when mothers are breastfeeding, that a lot of times if you're on Medicaid, you have to go to WIC and get the breast pumps, and that's after you leave the hospital, which is a loss. We have an opportune time when the mothers are in the hospital, and we worked with WIC to make sure that we had the breast pumps in the hospital before the mothers left, and just that one maneuver really improved our breastfeeding in our African-American mothers. So thank you.
Yeah, that's a great story. Thank you so much. Our next question is for Dr. Bahl. What technical challenges, if any, do you face trying to stabilize the baby while the baby is receiving KMC?
Yeah, thank you for that question. I would like to start the answer by saying that our study and the work we have done challenges the paradigm of current practice, which probably is not highly scientific. If we look at the science, probably it suggests that separating a preterm baby from his or her mother contributes to continued instability rather than making the baby easier to stabilize. However, having said that, we did face technical challenges for the simple reason that the staff, the providers, are not used to having the mother and providing the stabilization, etc., the care in a skin-to-skin position. So for instance, doing CPAP on a baby who is a preterm baby lying on his or her back with almost not moving at all is so much easier. But it took a little while for the providers to see how to work with the mother to be able to do that, to provide the same care, the same respiratory support, any other care with the mother. But once they started doing that, it was very easy to do that. The second thing was that from the very beginning, we were worried about monitoring, that it might become more difficult to monitor a baby in KMC position. So we did add a continuous monitoring with, let's say, pulse oximeter, something simple to keep monitoring the heart rate and the SpO2. However, again, we found that the mother is a great monitor of her own baby and was able to bring to the attention the problems of the baby much faster than when the nurses or the doctors, which are usually understaffed newborn care units, were able to do. So in principle, there are small technical challenges which one would have to overcome. However, they are not insurmountable, and they are not probably are more in our minds than probably are necessary. Over.
Thank you so much. And we are winding up on time, but we have one more question for Dr. Ezeaka. The question is, what was nursing's role in the development and rollout of NEST 360? They weren't explicitly mentioned as a stakeholder.
Thank you very much for this very critical question. The nurses are the key leads for the program, because all through the presentation, we tend to speak about clinicians, frontline workers. These clinicians include the nurses, include the pediatricians, include the medical officers, include the midwives and the nursing, school of nursing. So for us in the country, when we say stakeholders, starting from the initial rollout, the main stakeholders included these key professional associations, both their regulatory bodies, which is the Nursing Council, and the in-service component. So they were with us in the planning. Beyond the planning, the nurses were also integral parts of the newborn technical subcommittee, their heads and leadership, and they attended all these key stakeholders meeting to develop the document. And beyond that, when we were now rolling out in the training included didactic lectures on newborn comorbidities. We needed to teach about respiratory support, prematurity, jaundice, asphyxia, and these are key comorbidities in the newborns. The nurses were all with us every step of the way. And then the equipment too. Beyond learning about the morbidities, we now have the training on the equipment needed to give quality newborn care. And some of these were all in development and has been rolled out in the country. One key example is, which I also saw on the chart, was on oxygen, monitoring oxygen. Not only did they receive lectures and practice on oxygen concentrators, we also had lectures on the bubble CPAP machine that is meant to prevent lung collapse in these babies. And the nurses actually took the lead. They even brought pre-service components, not just the in-service, also the pre-service, where we had students from the School of Midwifery and students from the School of Nursing, because we believe that pre-service is also key, because by the time they've heard about this equipment and known how to use them in their pre-service, by the time they come to the in-service section, it will be a seamless transition for them. So nurses have been with us all through the development and the rollout. And even as national facilitators, now that the country is planning a national pool of trainers for comprehensive newborn care in the country, we have the nurses as part of the facilitators, and in addition to neonatologists and biomedical engineers as the critical core facilitators, and trainers. So this is very crucial. Every aspect of the program articulates and includes the nursing component. Very important. Thank you very much.
Thank you so much to all our panelists and to the audience today. When we were organizing this panel, we really had an opportunity to invite people that are our heroes in working all across the world to improve outcomes for newborns. And it's been just such a joy to share the last hour with Dr. Gupta, Dr. Ezeaka, Dr. Guillory, and Dr. Bahl.
Thank you so much. And thank you also to our attendees who added some amazing questions. And we hope that you really enjoyed your time this last hour.